Great. So I would like to introduce today's speaker, Dr. Serena Kiani, who is going to talk to us about clinical immunology in allergic diseases. Serena is a consultant in clinical immunology and educational lead for immunology at Barts Health, and he's also an honorary honorary senior lecturer at Queen Mary University, London. Thank you so much, Serena, for joining us today.
Thank you for the introduction. I'm going to start this straight away because I know we haven't got much time. So I'm going to share my screen with you. So good evening, everyone. I hope you can see this screen. Serena, is that okay? Can you see the screen before I get started? Okay.
Yeah, that's good.
So the talk today is very basic. Because it's not really for specialists in allergy, it's for a general medic, for a general pediatrician to get a feel for allergy. So I apologize for people who know more allergy than the basics, and I hope you forgive me and you don't get too bored. The good thing about these talks is that you could turn your computer off whenever you feel like it. So is going to be what I'm going to talk about is that how to distinguish what is presented to us as allergy. So a lot of people feel they have allergy. People come and say, you know, I have an allergy. What they mean is they've got a rash. I hope that with this talk I can give you an overview. I will first talk about hypersensitivity mechanisms, then signs and symptoms of different types of hypersensitivity which can present to allergy departments. Then I'll talk about asthma and eczema and their relationship with the allergy, because a lot of people think asthma and eczema are just pure allergy. And then we'll talk about some differential diagnosis of presentations, how you would investigate, and talk about a few cases. So this is all Jelen-Kuhn classification of hypersensitivity reactions. Type 1 hypersensitivity is IgE mediated. IgE is an antibody which was meant to be for parasites, but we can produce IgE to things which are not parasitic and actually not harmful. And that's when we have the classic form of allergy. It's mediated through mast cells, and we'll talk about that as well. The other hypersensitivities, type 4 can also mimic and appear to us or come to allergy clinic, and it's something to distinguish from type 1 hypersensitivity, and it's not mediated by IgE, and it is T-cell mediated, and it's called delay type hypersensitivity. The other two usually don't present to us in allergy departments, although in some forms or shapes can sometimes. So the diseases which are as a result of type 1 hypersensitivity are rhinoconjunctivitis, or some of the diseases, I would say, food allergy, certain type of asthma, not all asthma which is usually triggered by, for example, seasonal exposure to pollen or specific allergens, and some anaphylaxis also can be as a result of type 1 hypersensitivity. This is a diagrammatic representation of what happens in type 1 hypersensitivity, and I'm going to break it down into two sections. So first is the effector side of it. So basically, effector side is in the immune system, there is a detector side and an effector side. The effector side of it is what actually causes the allergic reaction, what you see, or the outcome of a reaction. So this is mediated in terms of type 1 hypersensitivity, it's mediated by mast cells. Mast cells were designed to fight with parasites mainly through evolution. They contain sackfuls of enzymes and mediators which can cause tissue damage to both parasites and to the individual. So some of the mediators also result in vasodilatation and release signals to pull in the rest of the immune system, and that's why you might see, for example, erythema in the skin as a result of the activity of mast cells. Mast cells on the surface have a receptor for a protein called IgE, or antibody called IgE, and this antibody binds the antigen, which in terms of allergy is called an allergen, when in terms of in parasites it would be a parasitic molecule, and activate mast cells to release these substances. IgE in turn is produced by B cells, certain B cells which have been directed to switch their production of antibodies to Ig. So normally B cells start producing IgM and then switch to producing Ig, something else, some other immunoglobulin. And in this case, because of certain signals, some of them back from mast cells, some of them come from the orchestrators of the immunity or immune system, which are T helper cells. And of T helper 1 and T helper 2. In this case, what they're called T helper 2 cells, you might have heard responses. Now, T helper 2 responses usually make B cells produce IgE by producing certain cytokines or signals, such as IL-4. And T helper 2 cells together see the antigen, but not the whole antigen. They see a small part of antigen, which is bound to major histocompatibility complex class 2, MHC class 2, on antigen-presenting cells. Antigen-presenting cells are things like dendritic cells or macrophages, which go around the body and pick up all sorts of antigens. And what, if you think about antigens as just three-dimensional shapes, they could be three-dimensional shapes from ourselves, or they could be three-dimensional shapes from pathogens. And the way they can distinguish this is that there is always other signals around here, which are basically picked up by these antigen-presenting cells. These signals are called pathogen-associated molecular patterns. So there are certain patterns, certain molecules from, for example, a parasite, which are not found in the human world. And we have receptors for them, which are called pattern recognition receptors, or PRRs. Pattern recognition receptors pick up the pattern from the pathogen, and as a result of that, they see that particular antigen coming from a world of danger. So they would let the T cells know. So they would produce what's called a co-stimulatory signal, activate the T cells, and those T cells then activate the B cells, and so on. The features of type 1 hypersensitivity are that it's also called immediate hypersensitivity. So it's quite quick. It happens within minutes to hours. Rarely you can have a few hours between exposure and a reaction, exposure to the allergen. And just to go back, one point I missed here, which I think I should mention it before we go further. Over here, the reason we react is not clear. Why do we react to milk, which is not dangerous? And normally we know that we should be producing reactions, or by evolution we produce reaction to three-dimensional shapes which come from the world of danger. So where is this second signal comes from in terms of allergen? And probably a lot of it is to do with our susceptibility or sensitivity that we inherit, or it could be because of context and various other things which happen at the same time, but that's the big mystery. To go back here, type 1 hypersensitivity is quite quick. There's one exception that you could get IgE-mediated reaction, which is it takes a few hours, up to 3-4 hours, and that's in the case of various types of meat, for example, pork, lamb, beef. They can take up to about 4 or 5 hours, and it could be because the allergen has to be processed before it's actually exposed to the IgE in the patient body. And normally the allergen is something called alpha-gal, which can be acquired by in meat is called alpha-gal, which can be acquired by insect bites. But we won't go into that. Often the type 1 hypersensitivity happens within minutes or an hour or two of exposure. You can have a secondary or a later reaction, but that's part of the same reaction, and that's a late phase reaction that you can get sometimes in up to 20% of the cases. Normally in type 1 hypersensitivity, there's a good pattern. People come and tell you it happens every weekday, but not at weekends, or there is some sort of consistency. They are not inconsistent, although sometimes they can be, and that is as a result of lack of what we described before, cofactors, which we might talk about again in a minute. But usually this history is quite telling when somebody comes and talks about a specific type 1 reaction rather than other reactions. The sites which are affected is skin, as we know, respiratory tract by bronchospasm, cardiovascular system by hypertension and tachycardia, and GI tract might be affected in some cases, especially in children, and that's by persistent vomiting or profuse diarrhea. So the signs and symptoms are these, as I mentioned earlier. We move on to the next thing, and this is now a type 1 hypersensitivity reaction type rash. And I'll put this one up. This is not really an interactive session. I would like to ask people to tell me what they think it is. But because I can't do that, I'll just tell you this is urticaria. And it's what's special about urticaria is that actually it's got a smooth surface, it's erythematous. It's raised, but it could be flat in some places, which is just pure erythema. Urticaria can be very itchy and sometimes even burning sensation. And this is as a result of the activity of mast cells or release of substances by mast cells in the superficial layers of the skin, which results in vasodilatation. I'm going to move on now to talk about relationship of type 1 hypersensitivity with a disease such as asthma, because I think general public think asthma is allergy, and even some doctors might think asthma is just pure allergy. There are basically different types of asthma. You can have, this is a very simple diagram from 2012, but it helps illustrate this. Some asthma can be triggered by allergens such as house dust mite or pollen. Some asthma can be triggered by irritants, not by those particular allergens, not because of IgE mediated reaction. And some asthma is because of genetic susceptibilities, and the reason for the trigger is not quite clear. And there could be overlaps between these. I've just put this one up here. This is an old table which talks about asthma endotypes. I'm sure you've heard about this by now because this was kind of a new thing about 2010 or so, or a bit earlier. But by that time, there were about 7 different endotypes. I don't know how many endotypes there are now. I haven't really kept up with them. But the endotypes are just, it shows the diversity of what asthma is. There are different types of triggers, there are different frequency or severity of disease, or different, they respond to different types of asthma, respond to different treatments, some irresponsive to, unresponsive to corticosteroids, some of them are. And asthma really, again, I'll put in this complicated mechanism of asthma, not for you to memorize, just to illustrate that asthma is not just a type 2 hypersensitivity or IgE mediated. Asthma can be as a result of many cells, activity of many cells such as basophils, eosinophils, and mast cells, and they can actually produce inflammation and cause tissue damage and remodeling, which then it could become independent of Th2 activity and continue having inflammation without any involvement of an allergen or IgE. On the other hand, even non-immune cells such as epithelial cells in some patients could be contributing to having asthma, for example, by producing mediators such as IL-33 or IL-25 or TSLP, which mainly stimulates Th2, or sometimes the epithelial cells are hypo-responsive to infection. So we have an innate immunity within our epithelial cells. When you get infected by a virus, your epithelial cells produce interferon alpha mainly, and that can kill or stop viral replication. But if the epithelial cells are not working very well, then you have to employ the rest of, so epithelial cells come from innate immunity, primitive, but you'll have to employ your adaptive immunity and bring in your other cells. And for example, there's a theory that in smokers there's neutrophilic asthma, or more neutrophils involved in the asthma, and that probably is because that you don't get a good enough interferon response by the epithelial cells. Here is a mechanism of eczema for you to memorize. Eczema, again, has always been thought that it's allergy, but it's really allergy might play eczema, may play a role in some people's eczema, mainly maybe in children. And maybe at the beginning of having eczema, you can have allergic reactions, but eczema now is thought to be a problem, a barrier failure of the skin. And we have mutations called flagrin, which results in breakdown of skin barriers, and as a result of that, you get translocation of allergens, and that presentation of allergen in the wrong place, food, for example, which should be presented by the gut, result in tolerance, may be presented via the skin and cause a reaction, an immune reaction. And that's the context that I talked about earlier, that sometimes the context of presentation of the antigen make it an allergen. But also you can get translocation of bacteria such as Staph aureus, and the endotoxin, the Staph aureus superantigens can cause inflammation, a Th1 type of inflammation. And then over time, the chronic eczema could be really as a result of this form of inflammation. And that's many people who are allergists here know that in some, even children, treating that infection of the skin really treats the eczema better than trying to treat them with anything to do with allergy. And yes, people with eczema may have allergy, but the allergy may not be contributing to their eczema, although in some it may. And then in adults, food exclusion diets usually don't work for eczema. And that's probably the reason that chronic eczema is not really type 1 hypersensitivity. So this is a bit of a summary of what I just said. The other thing I wanted to add is that atopy, what is atopy? In atopy, you get very high total IgE. And I've seen many people say, this patient has got really high IgE, they must have an allergy. It's possible they have allergy, but atopy is asthma, eczema, hay fever. And people who have atopy, or even they have first degree relatives who have atopy, may have a higher level of total IgE. We get so many people with high total IgE that I feel we need to change the reference ranges in our labs for total IgE. So total IgE alone, if it's high, doesn't mean you've got allergy, type 1 hypersensitivity. It could mean that you have atopy, or you might have allergy as well, but it doesn't necessarily mean that. The other things I've already talked about, and I just wanted to say asthma and eczema are quite heterogeneous diseases. So move on to type 4 hypersensitivity. And these are some of the diseases which can be caused by type 4 hypersensitivity. What you might see in an allergy department is some drug allergies could be as a result of type 4, although some drug allergies are as a result of type 1. The other thing is contact dermatitis, which could be a type 4 hypersensitivity. And then there are certain infections such as TB or some inflammatory bowel disease or some autoimmune diseases could be as a result of type 4. Type 4 hypersensitivity involves cells, T cells. This is a diagrammatic representation of what happens, and I'll go through it slowly. Again, very similar to type 1. You first have exposure to the antigen, which may be an allergen. And that exposure is the antigen presenting cells, macrophages or dendritic cells, pick it up, break it down, put a piece of this antigen, attach it to MHC class 2 on their surface, and they show it to T cells which recognize this, because these T cells are pre-made, ready to go with these T cell receptors which are randomly made, and by chance one of them will fit this particular antigen. And then because of the context of presentation and what might be going around there, this dendritic cell gives signals to make this T cell a Th1 cell, T helper 1 cell, or maybe T helper 1 cells are more selected to come to that area. But it's probably that you have something called Th0, and Th0 becomes a Th1 cell because of the context, because this dendritic cell has calculated it and decided that this is a better response, a Th1 response. Although in terms of hypersensitivity, it's actually making a mistake. That T cell becomes effector T cells, a T cell, and some of those T cells become memory T cells, and those memory T cells go and rest and wait for next attack. But at that time, the first exposure, the reaction takes a few days, maybe 2-3 days to see a reaction, but that results in that T cell migrating into an area where that antigen or allergen can be found, and they're recruiting other cells such as neutrophils and basophils, other immune cells, to cause the tissue damage or cause the inflammation, or, you know, really the plan was to kill a parasite, or sorry, to kill a bacteria maybe, or an infected viral cell. But here, because it's against an allergen, it's actually going to cause damage to our own cells. At the time of a second exposure, memory T cells would come in, and these memory T cells need very little antigen. They don't really need that much stimulation. They do need antigen presenting cells, but they don't need the very professional ones like dendritic cells. They could be activated by other cells, and so the reaction is a bit quicker, so it might happen a bit sooner, maybe within 12 hours or 1 day rather than 3 to 4 days. The signs and symptoms of type 4 hypersensitivity include rashes, mucosal ulceration, so it's a bit more severe. The damage is more severe when T cells are involved. You get tissue damage, you can get fever and constitutional symptoms. This is a picture of a rash as a result of type 4 hypersensitivity. It could be anything, could be drug reaction, less likely could be contact dermatitis. But this is, as you can see, is very grainy. It doesn't look like this one, which is the urticaria. It's more angry. This is eczema, so partly could be you know, type 4 reaction, but there are probably other forms of inflammation involved. This is a severe pustular eczema, and these pictures, as you can see, they're probably as a result of contact dermatitis, maybe with makeup or with cheap jewelry, cheap metal, and you can see it happens at the site of contact. I've put in names of lots of stuff just for you to see that it's almost unlimited, the number of things which can cause contact dermatitis. Contact dermatitis, again, it's type 4, it's mediated by T cells. It's no good doing IgE tests. And people, we run a lab at Barts in London, people send samples of what ask you to do IgE to nickel. But really, that's not the test you're looking for, because it's not mediated by IgE. We don't have a IgE test for nickel. The thing to do is patch testing, and patch testing is different from skin prick test, which I'll talk about in a minute, because again, that's something people make mistakes about, and they think it's all the same. Patch testing traditionally in this country is done by dermatologists and not allergists or immunologists for some reason. Right, so this picture is to remind me that I'm going to now talk to you a little bit about mast cells. These are mast cells. These are actually mast cells, and what you can see is the grains in the mast cells, or the granules of mast cells, which they discharge when they become activated. It's called mast cell degranulation. These mast cells have thousands of receptors on their surfaces, and the things which can trigger, one of those receptors is an IgE receptor, and what, as we've been talking about, IgE can trigger mast cell activation, but other things such as complement activation can result in mast cell activation. And if you've got an infection, you can get mast cell activation through complement system, because complement has been activated to fight the bacteria, but it also can activate the mast cells. That's why you get a lot of children get rashes when they've got infections, and they're mistaken for having allergies. There is something else about mast cell activation which is interesting. I mean, I just put complement, but there are many other pathways of activating mast cells. There is something about mast cell activation, that's threshold. There is a threshold for activation of mast cells, and we know things like stress, alcohol, infection, or even exercise in some people can bring the threshold down. And this is when you might have somebody who normally would actually, so sometimes this is without presence of any allergy, these factors can result in mast cell activation and degranulation. Sometimes there's a small amount of IgE, and people normally tolerate, that person might normally tolerate that allergen, but in the context of these co-stimulatory situations, such as alcohol or infection, they can then have allergy or mast cell degranulation. I mean, there's one interesting diagnosis, which is called basically food-induced food-induced, no, I can't remember it. Could anybody remember this? It's food-induced.
Exercise-dependent food-induced anaphylaxis, isn't it?
Thank you very much. Exercise-induced food-dependent anaphylaxis, which is within that that category. Then the other way for mast cell degranulation is direct degranulation of mast cells. So mast cells can of possibly directly degranulate as a result of possibly binding of certain molecules on the surface, not through IgE or IgE receptor, but also as a result of pharmacological action of certain drugs. For example, non-steroidal anti-inflammatories. I've put in here the triggers of mast cells. As you can see, there are again many of them, 2 pages of it. So you can see that not all mast cell activity is as a result of allergy. This is urticaria, and that's superficial degranulation of mast cells right under the skin. And this is angioedema, and it could be via mast cell degranulation in the deep layers of the skin, deep tissue, or it could be mediated by a different mechanism, which is called bradykinin-mediated angioedema, which I will mention in a minute. So if you have presentation of this or this, and this could be with or without rashes, this is your differential diagnosis. It could be either allergy to something and it's IgE mediated, or it could be more commonly, and more common presentation is urticaria angioedema, which is a condition found in about 3% of the world population sometime in their lives. If it continues for more than 6 weeks, we call it chronic urticaria angioedema by convention. Majority are spontaneous, so the cause is never found. Some is because of physical things, such as, for example, exposure to water, exposure to sun, so the aquagenic or solar. Some because of exercise, some because of sweating, cholinergic, and some are associated with autoimmune diseases. People with organ-specific autoimmunity can have a lot of that, or even people with connective tissue disease, which I've mentioned down here. The other differential diagnosis for the presentation like that is basically, as I said earlier, pharmacological effect of drugs, but also food can have some sort of pharmacological effect that can result in that. Then other differential diagnosis is whether this is contact urticaria, which is also possible, or contact dermatitis. So these are different types. So one is mast cells, one is not. And then the history and the timing can tell us which one it could be. And then, of course, the parasitic infection, what mast cells were designed to do really could be as a result of, could result in this form of presentation. And there is an entity called vasculitic urticaria, which looks very much like urticaria angioedema, but it's more severe. There's evidence of vasculitis, longer rashes and swellings, and might leave bruising, and that's something which needs to be investigated. And then sometimes you get association with lymphoproliferative disease or mastocytosis, which is a form of mast cell clonal expansion. Or even in Cox syndrome, you could get similar signs and symptoms. The history that one needs to get for this sort of presentation, rash or swelling, urticaria angioedema, is as follows, and I won't go through all of it, but the timing is really important, and whether there's a pattern or not. Often in this case, when it's urticaria angioedema, there is no specific pattern. People come and say, oh, well, sometimes it happens after eating eggs, sometimes it doesn't, and I can't tolerate it. That's often not because of the eggs, and it's because of this. And then you ask about drugs, you ask about physical, temperature, pressure, exercise, whether there are any systemic symptoms, You want to find out about travel history to find out whether it could be parasitic infection or not. You want to find out whether they're atopic individuals or they have autoimmune disease or the family history of autoimmune disease or not. And if it's pure swelling, you want to know whether they have a family history of swellings, whether this is something called hereditary angioedema. How you would investigate someone for allergy is if you suspect that it's actually allergic type, then what you need to do is to look for evidence of specific IgE against that particular allergen. And the test used to be called RAST test. You can do that by blood tests, or you could do that by skin test. And the skin tests are skin prick test, which is basically the first stage. Or you might do prick test when you don't have a particular reagent. You might actually use, for example, a whole apple and do prick test, or raw egg and do prick test, for example. Or if you're doing you're testing for drugs, you might go from skin prick test to intradermal test, which is basically more exposure to the allergen before you go to the most important test that you can do, or the gold standard of allergy test, which is challenge or propagation test. There's something else also called basophil activation test, which is not used that often, but still can be helpful in some cases. And basically, that's just looking to see, you take a serum from a patient and you send it off to see whether it, I won't go through it because we don't have enough time. So these are the tests that you do, but you have to be very cautious in how to interpret it, because so we have two things. One is called allergy, one is sensitization. Sensitization means you have a specific IgE against a certain allergen. For example, I might have IgE against milk, but I can drink milk without any problems. So, and here it says latent, but that doesn't necessarily mean you're going to get allergy. I don't like this terminology here, because basically there are people who have IgE, they're sensitized, but they're not allergic, and they're tolerating. Biologically, somehow they're tolerating. And the $60 million question is that why? And recently there's been a very interesting paper came out in Nature talking about cellulation of IgE. So it depends on the modification of the tail of IgE, and it seems like some people are susceptible to have a different form of modification, and that results in having IgE and having allergy, or not having allergy despite having IgE. Some people don't have IgE and they do have allergic type reactions. Again, that's not quite clear. It's a non-IgE hyperresponsiveness, which might even result in mast cell degranulation. In some cases, there are some studies which have shown there could be local IgE production. For example, nasal biopsies have shown presence of IgE to grass pollen, whereas when you take blood, you can't see IgE to grass pollen, or when you do skin prick test, you can't see evidence of presence of IgE. I put this here because if you send a specific IgE, and I hope if you're not an allergist, you're very careful when you're thinking about sending this. They send you this back, which is, the RAST grades. And RAST grades, but really RAST shouldn't be used. It's an old terminology when we use radioactivity for testing presence of specific IgE. We don't use that anymore, but the grades for RAST were like this. If it was less than 0.35, they called it negative, and it was 0. And then between certain is grade 1, 2, 3, 4, 5. As you can see, from here onwards, they call it positive. But I'm going to show you this. Specific IgE, we say positive is above 0.35. But this is just one study showing that the sensitivity and specificity, really, you needed to have a specific IgE for eggs of above 7 in order to have 95% specificity. But even at that time, your sensitivity was 61%, means you missed out something like 40% of the people who had it. Now, as you can see, for different age group, infants less than 2 years, that is 2 kilounits of allergy per liter. So it depends on the age, it depends on different allergens. For milk is different, for peanuts different. So you can't just rely on this RAST grading, which is really misleading. When it says positive, doesn't mean this person has allergy, it means they're sensitized. So the sensitivity and specificity for specific IgE vary with allergen, vary in different studies, vary with different assays. If you do skin prick test, one day might be different from another one. Depends how hard you push the prick. Sometimes two different people do it and they get different results. So what do we do to interpret IgE results or skin prick test results? We calculate the pre-test probability, and that's not, I'm not saying we sit down and actually do the maths, but you take a history, and based on that history, you decide whether this is likely to be allergic or not. And if it's likely, then if you have a positive result, then that actually multiplies the effect of that result. So that makes that result more likely, and it makes it more likely that this patient has allergy. The other thing I wanted to say here was that actually skin prick tests are a bit more sensitive, so pick up more patients than specific IgE or blood test. This I'll go back to this later a little bit. So I just wanted to introduce this idea of this other issue about investigation of allergy. So what I've got here is we've got peanuts, we've got a tree leaf, and we've got an apple. Each one of these has a number of different molecules which could be an allergen. But some of these molecules are the same between different things. So it's probably because these plants have common ancestries, and as a result of that, you have these shared components. And if I do a test, if I do a specific IgE test or a skin prick test, so what you're picking up maybe is all the IgE you have. So you would, I don't know whether how many of you know the principle of ELISA test. It's a similar thing what we use nowadays. It's not exactly ELISA, but you take, for example, a peanut or an apple, and you extract its proteins, and you coat it on a well, put in a serum, leave it till the antibodies of that patient bind it, then wash them off, then you go in with the anti-human IgE antibody, and you see whether they have this particular allergen, particular antibody against, say, peanuts. But if you're using whole extract of peanut, you might pick up these antibodies, which are also against parts of tree or a fruit or many other things, and that's called cross-reactivity. And with cross-reactivity, so when you do specific IgE tests, you might not pick up those allergen-specific tests if you're looking at the whole extracts. I've got an example here for you. That's peanuts, and peanut. The way we get around this, or the way we actually can get a bit more information, is about what's called component analysis. Peanut is made out of many allergens. You've got something called ARO-H or Arachis H8. This is a short piece of peptide from a molecule in peanuts called PR10. PR10 protein are found in many plants, and they're part of the immune system of the plant. And these are very flimsy molecules. They can break down as soon as you heat them or by processing, and they can cause something called oral allergy syndrome, and we'll talk about that later on with some cases. The other parts of peanut, there are other molecules such as RH1, H2, and H3, which come from a protein which is the storage proteins, and they are really hardy proteins, and they can't break down by just gentle heating or sometimes even by baking, and they don't break down. So if you are allergic to those and you eat peanuts, you can get a very severe reaction. And there are other proteins, RH9, which comes from membrane lipid transferase, which is a protein which again found in many different molecules in many different food, and people can have multiple food allergies or appear to have multiple food allergies, but they can actually clinically also have multiple food allergies. So this is, in some ways, as somebody once described it, it's like doing a specific IgE is like doing a chest x-ray Doing component is like doing a CT scan. You see more details of what they're allergic to. So I'm going to go through 6 cases now and carry on giving you some other new ideas as well. So the first case is a 72-year-old retired accountant, hypertension for 6 years on ramipril and statin, heart attack a year ago, on bisoprolol and aspirin since then. He's had facial swelling every few weeks since 8 months ago. In the last month, 2 episodes of tongue swelling overnight, called an ambulance. He was treated with prednisolone and antihistamines, taken to A&E for observation, but that didn't really help. They gave him an adrenaline to carry. And that's hopefully doesn't happen nowadays anymore. And people realize what it is because they told him to go and carry on with your ramipril. This is, as you probably all know, ACE inhibitor induced angioedema. So that would look exactly like the picture I showed you of mast cell mediated angioedema, where there is no rashes, but it's nothing to do with mast cells. This is a little audit we did when I was in Surrey, and this was people coming with isolated angioedema to A&E department. Majority of them, 49% of them, we called it idiopathic because we were idiots and couldn't find a reason why they had it. 24% was actually ACE inhibitor mediated, and then there were other things. Allergy was about 13%, so IgE mediated was 13%. This is to do with this area, really. Some of this is really not representative of what happens, but actually it's not too bad. When you look here, this is actually from UpToDate. I had to look at UpToDate to compare it. It's quite similar. A lot of idiopathic angioedema. They have a lot of C1 inhibitor deficiency, which I'll mention in a minute. But that's really amazing, actually. I don't quite understand that because this is 1 in 50,000 disease. 1 in 50,000 people have this. So it's very odd here to have 25% of cases. Maybe that's selected, though. That could be selected in a clinic. Now, what is bradykinin-mediated angioedema as opposed to mast cell-mediated? Bradykinin is a small molecule. Once it's produced, it lasts about 10 seconds. It binds bradykinin receptor 1 and 2. Bradykinin receptor 2 causes breakdown of gap junctions, extravasation of fluid, and edema in deep layers of the skin, and that's angioedema. And bradykinin is produced from a bigger molecule, high molecular weight kininogen, by the activity of an enzyme called kallikrein. And activation starts from the contact system, but we won't go into that. What inhibits this activity of kallikrein is something called C1 esterase inhibitor. C1 esterase inhibitor is missing or is dysfunctional in patients who have hereditary angioedema type 1 or type 2. There are other types nowadays which has nothing to do with C1 inhibitor. But this is bradykinin-mediated angioedema. There's no mast cells around whatsoever. And I want to show you why does ACE inhibitors cause the same problem. It's because they increase bradykinin production, and how they do it is that ACE inhibitors can inhibit their job. We use them for hypertension to stop angiotensin 1 becoming angiotensin 2, but they can also inhibit breakdown of bradykinin, because bradykinin, as I say, within 10 seconds breaks down into an inactive short peptides or even amino acids. But ACE inhibitors stop that. So that's why we get ACE inhibitor angioedema. And normally when you stop the ACE inhibitor, it takes maybe a week, 2 weeks, some people a couple of months when they stop having swelling. So the swelling can go on for a bit longer in some people. In some people, the swelling can carry on. So that would just unleash something. The first use of ACE inhibitors will just result in discovering the genetic abnormality. And so far, plasminogen gene mutations have been shown to sometimes work like that. So they present in late life and sometimes after first dose of ACE inhibitors. This is a typical ACE inhibitor angioedema. This is not just a minor, so it could be smaller swelling, but what's important about bradykinin-mediated angioedema is that, first of all, there is no rash. Second of all, there is distortion of the contours of, for example, the lip. It's not like as if there's a bit of lip puckering or a bit of edema. It's usually distortion of the contours. So another case now, this is now moving on. 16-year-old boy doing GCSE, he's got hay fever late spring, got exams coming up, itchy eyes, sneezing, stuffy nose, blocked ears, and itchy palate. Takes over-the-counter antihistamines on a PRN basis, wants to know if there is a cure as he's fed up. So the reason I put this case up was because I wanted to show you that actually, yes, so this is hay fever, as you all know, and this is sort of a rough guide about when these things are around, but it depends very much on you know, the temperature, the global warming temperature, whereabouts you are in the world. But these are some of the, sometimes you get seasonal symptoms, sometimes you get perennial symptoms, and perennial symptoms, it could be that you're allergic to many different allergens from different seasons, or it could be something like house dust mite, which is, or an animal in your household, a pet in your household. The reason I put this up here is that he wants a cure, and yes, you can use desensitization by a small exposure to the allergen for a period of 3 to 5 years. But the first thing you do, you put them on regular antihistamines, you give them nasal sprays, and if they don't respond to that, you may want to consider using desensitization, which is a big commitment, especially for a teenager. Case 3 is a 31-year-old teacher, itchy mouth and lip after eating apples and peach, cherries, raw carrots, hazelnuts, potatoes makes their eyes water when they peel them, raw potatoes. They can eat apple pie and tinned peaches, and there are no symptoms when they eat cooked fruit. They have hay fever in May and have mild asthma and eczema. And this is a typical case of somebody being allergic to that component, which is flimsy, the PR10 component, and it can, which breaks down by processing and heating. And that component can be found in grass, it can be found in in tree pollen, it can be found in a variety of fruit and vegetable, as well as some nuts as well. And that gives you oral allergy syndrome, which I've got a summary here of what it is, and I won't go through it again, as I think we're running out of time. Case 4 is a 20-year-old woman with asthma as a child and hay fever, and they get asthma symptoms mainly in autumn. Okay, so maybe, you know, this patient has got in autumn, so if asthma symptoms mainly in autumn, so you start wondering, is this some sort of a allergic type asthma? What are the allergens in autumn? You might want to test them against air allergens and find out whether that's the case, and see whether avoidance, by the way, is the first thing, which I should have said about the boy who's doing GCSE. This, but it's not always that easy to avoid certain allergens. But in this case, the reason I put this one up was that, so you look at the timing of the allergen and you might decide to do certain tests. But also I put this up because to say that actually, let's say this wasn't just in autumn, and this was other times as well. There was a big study done in children, the ARIA study showed there's children with rhinitis who also had asthma, and they looked at treatment of rhinitis had a massive impact on asthma. It really improved asthma. So to put it in a sort of a very basic thing to remember, it seems like, you know, the bit your nose first receives the allergen, and it's the receptor for the allergen, which then triggers a reaction in the lungs. So it's very important to treat rhinitis in patients who have, although rhinitis usually is not considered a very significant disease in some people, and some people it's debilitating, but it's important to treat rhinitis if they have asthma as well. Another case, a 54-year-old woman with itchy rash, lip swelling for 6 months, comes more regularly to A&E, been given prednisolone, antihistamines, adrenaline auto-injectors, is on a very restricted diet. And this is, I'm not making these cases up. These are people we've seen before, and I'm sure allergists in the group have seen them before, because they think they're allergic to everything, because they've been having recurrent reactions, sometimes even every time after they eat, but it could be anything they eat. And this case, really, I put this up here because I wanted to remind you that case of urticaria angioedema. And urticaria angioedema can present like this, and what you need to do for that is to make sure the history is not suggestive of a particular allergy. Put them on regular antihistamines up to 4-time normal doses. So you might want to start with, for example, loratadine or fexofenadine, 1 tablet a day. And if they're not responding after 2 to 3 days, double it and then quadruple it. And then if you've done that and they're still having significant number of reactions, you might want to add in montelukast, and so on and so forth. There are other things one can do as well if they don't react. But what I want to say is the most common presentation is not usually allergy, but it's to do with mast cell activity. Case 6, this is a 12-year-old girl who has recurrent severe abdominal pain. So this is our last case. Multiple A&E visits, suspected recurrent appendicitis. She never had an operation. She never was, because they sat and watched and see how things go. And actually there was no rise in CRP or inflammatory markers were down. But there are many people actually with this sort of presentation who've had multiple scars in their abdomen because they've gone into their abdomen often. You take a history and you see that she tells you that she's also had a couple of episodes of lip swelling and also 1 episode of hand swelling after a bit of minor trauma. Never has rashes. Whether they have swelling or no swelling, there's no rashes. And this is really bradykinin-mediated angioedema. I thought I actually put some slides to talk about that a bit more. Oh yes, I did. So this is this type of angioedema. This is because of production of bradykinin. There is no rash. That's the hallmark of it. It could be family history, but 20% are de novo, so there is no family history. It could be because of C1 inhibitor deficiency, but not always. It could be other things. There are new genes identified. These crosses here is where C1 inhibitor inhibits the activity of, for example, kallikrein. And these patients don't have enough activity, so they have a lot of bradykinin production. So that's it. This is all my talk, and I'm happy to answer some questions. I think I might leave this one. Apples look nicer than swollen lip.
Thank you, Serena. That's very interesting, and I think it's always useful to go back to the basics of the immunology first to understand better what the clinical presentations and how the management of allergic diseases is as well. There is some time there. We have several minutes for questions. So if the audience have any questions, please type them into the chat. I have a few questions while we waited for the audience. I just wrote down. One actually is just about the last case, the bradykinin mediated angioedema. How do you make a diagnosis of that?
So bradykinin-mediated angioedema, the first thing you do C4 levels. You do C3 as well, but C4 is more important, and C for complement 4. So often, if it is C1, if it's C1 esterase inhibitor deficiency or hereditary angioedema type 1 or 2, your C4 levels are usually, well, should be low during attacks and sometimes in between attacks. But you might find that's normal, but the patients still have recurrent attacks. Your history is not suggestive of allergy. They're not on ACE inhibitors. Then, yes, they truly have swellings. Then you test by treating them with antihistamines. So there is urticaria angioedema that we talked about. There is a type of urticaria angioedema which is actually syn urticaria. It's only pure angioedema. So that's called, we call it, first we start calling it by idiopathic angioedema when we don't know what's caused it, but that idiopathic angioedema could be responsive to antihistamines, and that's not bradykinin mediated, although there might be some evidence that some bradykinin mediated, but I don't want to complicate this. Antihistamine responsiveness, so you try high doses of antihistamine for a good bit of time, 2 to 4 weeks. If they respond to it, then it's not bradykinin mediated. If they don't respond to it, then it's probably bradykinin mediated. Then you could try something like tranexamic acid. But we are setting up an assay now to actually stimulate this complement, the contact system. And by stimulating the contact system, we want to measure and see how much bradykinin they produce and see whether we could see a differential between people who have bradykinin-mediated angioedema and people who don't. So we're hoping to be able to demonstrate or have a functional test to show that somebody might have bradykinin-mediated angioedema. And then we've also got an NIHR grant to start the genetic analysis for all angioedemas in the UK at Barts. So if you have anything like that in it, it's all in place, but we haven't started because of COVID. We will do not whole genome analysis. We're going to look at 250 genes which interact with this pathway, with this particular pathway. Those 250 genes, we want to look and see whether there are any mutations which may actually be explaining the reason they have angioedema. Similar sort of people have had a look at plasminogen and found mutations there specifically, and people have had a look at angiopoietin 1 and found a couple of mutations. Factor 12 is another mutation which is mainly in women as well. So we would be happy then to, if somebody's been proven to not respond to antihistamines, to either do this assay and find out whether they have a bradykinin-mediated disease, or do the genetics to see if there is a reason for it. But there are no good tests at the moment.
Surina,
yeah.
Can I ask you on that? I have a patient who had borderline low C4, but when we did the C1 esterase, both levels and function, that was normal. She hasn't really responded to top levels of H1 and H2 antihistamines, and I'm just converting her to belastin now. When they do have borderline low C4, is it worth repeating the C1 esterase levels and function again if they were normal before?
So C1 esterase is a suicide enzyme. So every time it acts, it actually is finished. It doesn't work anymore. After one activity, it basically is destroyed. So if your levels of C1 esterase function are low, it's worth repeating it, because we get a lot of false low levels because
no, they were normal. Yeah,
I understand. Yeah. I understand. So there is no point repeating when you have normal C1 esterase function and level. Now, C4 levels, you have a large number of general population who have what's called C4 null allele. And C4 null allele people have baseline low C4 levels. So that's absolutely okay and fine, except that sometimes you find in these people, they have a family history or themselves have a history of connective tissue disease. It's possible they're more susceptible to connective tissue disease. Null C4 is more common in people with connective tissue disease, but you can have a normal population as well. There is no point repeating it. I think you're doing the right thing. I would try and treat with something like, so you might try, for example, a progestogen such as Cerazette if they want to go on an oral contraceptive pill, if they're the right age and a woman who wants to do that. That sometimes helps with bradykinin-mediated angioedema. And in France, it's very popular. They use that a lot. Or you might want to use tranexamic acid. And if you're not having any response, we have other drugs, but they're really on named patient basis, and we are happy to receive referrals if you have anybody like that. We have a pediatric as well as adult angioedema swelling clinic at Barts.
Yeah, thank you.
Thank you. There is a question from the audience. It says, if a child is having recurrent multiple food allergies related anaphylaxis, then how should these be managed? As there are times we don't know the allergens.
So this is something probably George can answer better than me. You need to basically, first of all, investigate them. And I mentioned that there, you need to really find out and establish something like that. You really need to, and it depends very much on the history. You need to establish, are these really allergic reactions to these food? So you may have to challenge. You may have to challenge to find out whether they're true allergies or not. And then, you know, it's not something that I could tell you what to do from, you know, this lecture. This is incredibly difficult. It's really difficult. There are children with multiple food allergies, and it's really difficult to manage them. So it really on each case basis. I mean, if you have a specific question about something like that, we can talk about here, but I can't really say much more than that, unless you want to add anything.
And I think it's the history. You need to go back to the history and trying to see whether you can actually identify a common triggering food. And if it's with a lot of foods, you then need to start suspecting that this is probably not a food allergy, or it could be a sensitivity to some kind of additive. And that's what you may need to consider, either to sulfites or to benzoates or to something like that. But when you're having multiple foods involved, and especially all of a sudden, you need to really be questioning that. And it's not good to do general panels of specific IG, because you're just going to get more confused.
Absolutely, absolutely. Because you can have positive specific IG, as I mentioned, and there could be actually no allergy. And I agree that what you need to do is, if it's multiple, more than anything, you need to be more careful with the history and doubt more. And if you need to challenge. But this all has to be done in a specialist allergy clinic. And there are certain things, for example, LTP that I mentioned, you could get basically allergy to multiple food, or somebody might have multiple food allergies rather than just one allergen. But those are rare. And more commonly, this is actually something else. As George said, it could be having recurrent urticaria and edema, which is more common. It could be having recurrent mast cell activation because of, for example, again, preservatives, coloring, E numbers, sulfites, all sorts of things. So, but the history usually is quite, you know, helpful.
Hi, Serena. This is Satish here, one of the pediatric registrar in Royal London. And as Serena said, going back to basics and trying to understand the different types and different varieties is really useful. And thank you so much for providing this opportunity for us. My question is, again, going back to basic. One of the recent lectures, we had talk on non-IgE reaction, and eczema was included in that. It was presented as non-IgE. So would you agree that eczema is non-IgE reaction, or is there?
I would say, first of all, eczema is a spectrum of diseases, as I said before, and I would say most eczema is nothing to do with IgE. In some children, you can have some IgE-related inflammation, or a certain food can make their eczema worse, or yes, that's a possibility. But if we're talking about, we can't talk about eczema as one thing, first of all, and most eczema probably is as a result of other inflammatory diseases. It's your genetic susceptibility which makes you have eczema. Now, you may have food allergy in association, or you may have even exacerbation by food. But yes, I agree. Eczema is mostly not type 2 hypersensitivity.
Thank you. Thank you very much. And the antihistamines for eczema, it might work for some, and it might not work if it is a different mechanism.
Sorry, say again?
Antihistamines?
But they probably work, they help with the itchiness. They won't help with the pathogenesis. They help with the itchiness.
They won't, to be honest, they won't help with the itchiness of the eczema. So, because we see that prescribed a lot by the GP. So for the eczema, because the itchiness is because of IL-4 triggering the nerves. If you have urticaria in eczema, that's different, like spontaneous urticaria. But for eczema, we see that prescribed a lot. And actually, what you need is to switch off the T cells. So yeah, you need steroids.
When I ask parents, or when I tell parents that it might not be useful, because they'd be giving eczema the antihistamines, quite a lot of antihistamines, but still say, oh, my eczema is not better because your medication is not working. So when I try to tell them that it might not be directed towards those things, yeah, I'm having a tough time to explain.
Yeah, it is useful when you have eczema because of allergic rhinitis and they're kind of itching around that area. That's fine because that's IgE mediated. But because eczema is non-IgE, it doesn't make a difference, yeah, unfortunately.
For
some people, you should try the antihistamines. You should try the antihistamines because some people do benefit from the antihistamines with regards to itchiness, or it might, in the evening might help them sleep or so on. But really, what you need is to repair the skin barrier, and that might involve large quantities of emollients. It might involve skin cleansing, bleach baths. It might involve use of steroids, as George said, depending on really, it could be any of those things that you have to do.
So for those who are not responding to itchiness for antihistamines, there isn't any other medication which can reduce antihistamine, but just to give the holistic emollient, what you said just now, with the eczema treatment itself, that might reduce the itch.
Make the eczema better, basically. Yeah. There are other people who have intractable itch. There are clinics which do just itch, and there are various drugs that can be used for that, but it's not something we use routinely, and I don't do that. I would refer them to St. Thomas's Itch Clinic if I have to.
Yeah, thank you so much.
Okay, thank you very much. Thank you for an interesting talk and very interesting questions as well. Thank you, Serena. And I will leave on the screen some information about the Imperial College. I think I have it here. Yes, I will share it with you. There are Imperial College organizes postgraduate courses, both, I'm not sure whether you can see it.
No.
Here we go.
Oh, yeah.
Yeah. So they organize these postgraduate short, intensive 2-day courses, certificate, diploma, and MSc, and they are very, very helpful. They're very useful, and I'm an MSc student myself, and I found it very, very interesting and very, very good to build my foundation of theoretical knowledge in pediatric allergy. The other thing I wanted to remind you is the learning pack. So Ain has posted in the group before, in the group chat, the link to the learning pack and to the feedback for this evening session. So the session will be on the YouTube channel as well of the London School of Pediatrics. And that's it. Thank you very much and have a good evening.
Thank you.
Thank you.
Thank you. Thank you, Serena.
You're welcome. Bye.